Thanks a lot, Teresa, and thanks to all of you for coming out on this beautiful Thursday evening to talk about healthcare policy. I sort of feel like Zsa Zsa Gabor's seventh husband on their wedding night. I know what I'm supposed to do, and I'm going to try and make it interesting for you. So, the famous comedian Will Rogers, somebody said, "Don't you find it hard to write comedy and be a comedian and do what you do?" And he said, "No, not when you consider I have the entire government working for me." And that's sort of our take on this. Like Teresa said, I am a healthcare policy analyst. I work for a think tank called the Washington Policy Center. And we are a state-based, nonpartisan think tank. Our emphasis is on anything that has to do with the free market. And we are one of the largest state-based think tanks in the country. We have actually 4 offices: Seattle, Olympia, Tri-Cities, and Spokane. And we have 6 different divisions. Now, I'm the face of healthcare, but we also have environment, education, transportation. We have one fella in Olympia who's like a budget expert, a state budget expert, and then we have a lady who deals with small business. Now, on your tables is a real small little piece of paper here. We are, as I say, we're nonpartisan. We are non-tax supported. We're essentially a 501c3. And we're supported by individual donations. And what this card is, it's a 6-month free subscription to all of our publications, all of our events, announcements, and so forth. It gives you an idea of exactly what's going on at the Policy Center for 6 months. At the end of that time, if you say, I'm not too interested, we can part friends. If you are interested, then we send you an envelope. You can sign up and send us a contribution, and that's how we keep our doors open. So that's one of the housekeeping things I wanted to take care of. Then the other thing in front of you is the kind of material that we do at the Policy Center. This is a piece of work that we did last year. It's a compiling of 4 separate papers on the impact of the Affordable Care Act on the citizens of Washington State. Please take this, take as many as you'd like, give them to friends, family. I've got a stack over here. We want to get this information out. So please feel free to take as many as you like. And then, as Teresa said, I have written a book on the patient-centered solution. This goes over the history of how we got into the problem with our healthcare delivery system and what we see as workable solutions. We've been fortunate to have endorsements both regionally and nationally. Former Governor Jeb Bush has endorsed the book. Our Attorney General Rob McKenna has endorsed the book. $9.95 or tonight $10, and I'll pay Governor Gregoire the sales tax. So I have extra copies of that. So that's the housekeeping kind of stuff. What I'd like to do in the time tonight is actually 4 things. I want to give you a little bit of background on the Affordable Care Act, how that legislation came about. Then the second thing I want to do is tell you what is in the Affordable Care Act, or give you the main provisions. Let me put it that way. And then the third thing is, where do we stand today? We've had over 2 years now with this piece of legislation being the law of the land. So where do we stand today? And then the fourth thing, really briefly, is to kind of give you a little bit of history, sort of a synopsis of the Supreme Court decision from a couple of weeks ago. And so let's get started. The background on this legislation, come back in time with me to late 2008 and early 2009. And I don't know, I'm sure everyone in this room can remember what was going on then. We were in the middle of the worst recession that this country has seen since the Depression, right? And many of us still have scars, if not open wounds, from that time period. The American public was polled in early 2009, and they said, what are the most critical issues that you and your family face? And the top 2, well over 80% of Americans said the economy and jobs. 10% of people said health care. So what did Congress do for the next 13 months? They debated health care while our economy sort of languished, and it's still languishing if you want to actually look at it that way. So the entire year, essentially, of 2009 was taken up with the debate on health care. And ultimately, the Patient Protection and Affordable Care Act was signed into law, or the PPACA, or as I refer to it as the PPCACA Act. And so that's what was signed into law by President Obama. Now, this is the most unique piece of social legislation ever passed in the history of this country. Unique for a couple of reasons. First of all, there were no Republicans that voted for the ultimate legislation that passed. No Republicans. There were some Democrats that voted against it, but there were no Republicans. This is strictly a partisan piece of legislation, regardless of what the president tries to tell the country today. This was a partisan thing, and it was sort of rammed down the throats of the American public. That's number one. Number two is the legislation, the bill as passed, as signed into law, was 2,700 pages. Now, let me put this in perspective for you. Say what you want about Medicare, Medicaid today, but when they passed in 1965, they passed with majority support of Democrats and Republicans. The majority of the country was behind this legislation, and that entire piece of legislation was 137 pages. So right off the bat, you can see that this is a totally unique, different animal that we're dealing with the Affordable Care Act. Now, during the debate, the American public, we were told 5 things. First thing we were told was the Affordable Care Act is going to bend the rising cost curve of health care in this country. It's going to bend it down. Last year, healthcare was about 17.5% of our gross domestic product, or our economy. It was about $2.4 trillion. And the Affordable Care Act was supposed to bend that cost curve down. That's what we were told. Second thing we were told is if you like your current insurance plan, you will be able to keep it. The third thing we were told is this piece of legislation will provide universal coverage. Everyone in the country will have health care. A healthcare insurance plan. We were also told that the Affordable Care Act is going to eliminate waste, fraud, and abuse in our healthcare system. And then the last thing we were told is the Affordable Care Act will definitely improve the quality of healthcare in this country. So that's sort of background. That's how this came about. It's what the American public was told in 2009, 2010, March of 2010, when the legislation was signed into law. So, second thing we wanted to cover tonight, what is actually in the Affordable Care Act? And you can imagine, 2,700 pages, we could be here until Thanksgiving discussing all the little ramifications that are in here. But really there are some provisions that form the basis of this legislation, and it is not hard to understand, folks. The first thing is the individual mandate. And I'm sure you've all heard of actually all these things, but especially the individual mandate. What the individual mandate says is every adult over the age of 18 must buy a private product, health insurance. This has never ever been done in the history of the country, whereas a requirement for citizenship, our citizens must buy a private product or a private service. Now, people will say, well, yeah, Stark, but look, I drive a car and I got to have car insurance and that's a law, and yes, it is. But it's a state law, and essentially it's for liability only, and you can still be a citizen of Washington State and not drive a car. But this is a different deal, folks. This individual mandate says to be a citizen, you've got to purchase a private product. And that, of course, is what the Supreme Court decision was all about. Now, if you don't buy health insurance, then you pay a fine or a penalty or what is now called a tax. And that tax starts small, but ultimately over the next couple of years it will wind up being $700 a year or 2.5% of your gross income, whichever is larger. Now the average individual plan in this state is somewhere between $3,000 to $4,000 a year. So you can see $700 is considerably less than $3,000 or $4,000 per year. So, if you're out there and you're a healthy 25-year-old or 28-year-old, you've got a decision to make. Should I pay that tax or should I purchase health insurance? And that's going to be a critical issue going forward with this legislation. So that's the individual mandate. And we'll cover a little bit more in the last part of this when we talk about the Supreme Court decision. The second provision that you need to understand, which is one of the basics in the Affordable Care Act, is the employer mandate. And what the employer mandate says is if you're an employer and you have 50 or more employees, then you must provide health insurance or pay a fine or a penalty or what's now called a tax. Well, okay, except that tax is either $2,000 or $3,000 per employee per year. And there's a difference, and I have no idea why, but let me just briefly go over that with you. If you're an employer and you say, I don't want to be in the health care business, I don't want to provide benefits at all, then you will pay, as an employer, you'll pay $2,000 per employee per year as a tax. If you are Mr. Employer or Mrs. Employer and you say, I am going to provide health care benefits, but you have one or more employees who opt out and want to get their insurance on their own, then you will pay $3,000 per employee per year in tax. Okay, so I have no idea why they came up with different numbers like that. The critical thing here, though, is the average employer in the state of Washington last year paid between $10,000 to $12,000 per employee family per year for health care benefits. $10,000 to $12,000. Now, you don't have to be a math major to figure out that either $2,000 or $3,000 is considerably less than $10,000 to $12,000. And so, as an employer, a decision is going to have to be made. Do we continue to provide health care benefits, or do we not do that? Maybe pay a little bit more in salary, maybe not, but ultimately have our employees go out into the individual market and purchase their own health care benefits. And that is going to be a decision that employers are going to make. So individual mandate, the employer mandate, and then the third thing that you need to understand about the legislation is the insurance mandate, or are the insurance mandates. Let me put it that way. There are a number of people, perhaps rightfully so, who believe the entire piece of legislation is nothing but insurance reform, health insurance reform. And there's some logic behind that. There are a lot of insurance provisions in the law, but there are two that you need to be aware of and you need to understand because they're critical to the legislation. One, the first is called community rating. And what that means is that everyone goes into the same pot. Everyone goes into the same risk pool, no matter how old, how young, no matter how healthy, how sick you are. Everybody is in that same risk pool and paying about the same for health insurance premiums. So the young and the healthier will pay more for premiums. Older individuals who are sicker will pay less for premiums. We're kind of all in this together. That's called community rating. Then the second insurance mandate that you need to be aware of, and this is the critical one, is called guaranteed issue, or pre-existing conditions. And what that means is that as an insurance company, you cannot deny coverage, or you cannot deny an individual purchasing health insurance, regardless of how sick or how injured or how ill they are. So it's kind of like if you think of homeowners insurance, it's sort of like having your house burning and then you go to your insurance agent and buy homeowners insurance. Okay, that's the analogy. So community rating and guaranteed issue. Now, the problem with those two things, they may sound great, and a lot of people, I talk to a lot of folks and they shake their heads, that sounds like a good deal. The problem is insurance companies can't plan for and cannot mitigate risk. They have no idea how to price premiums if they are forced into this community rating and guaranteed issue. So I'm sure many of you in this room are already seeing your insurance premiums go up just over the last couple of years. And the huge, big reason for that is insurance companies, Regents, Primera, they're trying to anticipate where this is all going to sort out. Now, the real proponents of the Affordable Care Act, this pre-existing condition, that was the deal breaker for them. They said, we've got to have that in the legislation. So the insurance companies sitting at the table during the debate, they said, okay, fine, if you're going to do that, if you're going to put community rating, but especially this guaranteed issue clause on us, then we need everybody in the pool, and we need an individual mandate. So you can see how this whole thing kind of came full circle and wound up as 2,700 pages and took 13 months to debate this out. That is sort of how we came about this. As I say, there are 2,700 pages, there's a lot of stuff in there, but those are the basics, those are the fundamentals. Now, what is this thing going to cost us? Well, the Congressional Budget Office is a nonpartisan organization in Washington, D.C. And they look at any piece of legislation before it's passed, and they come up with an estimate of what it's going to cost for the first 10 years. The CBO just looks at the first 10 years. And the number the CBO came up with was $940 billion, and that would be the cost to the nation, and it would reduce the deficit by about $100 billion over the first 10 years. Now, the thing you need to understand is when the CBO, the Congressional Budget Office, looked at this, the way the law is written, it's written for 10 years of taxes, 10 years of money coming in other words, and 6 years of benefits, because the benefits really don't kick in until 2014. So you got 10 years of benefits, but 6 years of, 10 years of taxes and 6 years of benefits. So many of us in the policy world said, okay, even if you buy those numbers that they came up with, what happens in the second 10 years when you have 10 years of money coming in, but you also have 10 years of money going out? And we were concerned, and estimates now are in the $2 to $3 trillion range for the cost that second 10-year period of time. So you might ask, okay, well, let's look at the legislation. Where does that money go? $940 billion, we can round it up to $1 trillion. Where does the money go? It goes to two places, and two places only. After you take out 4 or 5% for administrative costs and overhead and things like that, and payment for the 160 new agencies and new bureaucratic organizations and so forth. After you take out administrative costs, the money is almost equally split, and it goes to two places. The first is to an expansion of Medicaid. Now, many of you probably have heard of Medicaid, but you don't know what it is. So let me take a minute here and sort of digress. Medicaid was passed in 1965, along with Medicare. Medicaid was passed. It was a safety net, a government safety net for kids of poor families. And it was financed by 50% state taxpayers, 50% federal taxpayers. Congress, when they passed Medicaid, they said, in no way is this program going to become huge and unmanageable, simply because state legislatures are not going to want to increase their Medicaid rolls. They're not going to want to keep putting money into this thing. And remember, they're on the hook for 50%. What happened, folks, was state legislatures looked at this and they said, wow, we spend $1 for education, we get $1's worth of education. We spend $1 for Medicaid, we get $2 in our Medicaid program. So what has happened since 1965 is Medicaid has become the top 1 or 2 budget item for every state in the union. Washington State is second behind K through 12 education, but it's rapidly closing that gap. Medicaid now is, it's an entitlement that is totally out of control. $450 billion cost, that is going to double by the year 2019 in the existing Medicaid. And the problem for our Medicaid patients is the reimbursements for providers, for doctors, nurses, and hospitals is terrible. It's 40% of what private insurance pays. And primary care doctors, family doctors, pediatricians, internal medicine doctors, they cannot pay their overhead with what Medicaid reimburses them. And so our existing Medicaid patients are having a difficult time accessing health care because providers can't, as I say, pay their overhead taking patients. So what the Affordable Care Act does is it adds somewhere between 16 to 20 million more people into Medicaid. It opens Medicaid to any adult making less than 133% of the federal poverty level. So what we're going to do is we're going to spend half the money in the Affordable Care Act dumping up to 20 million more people into a bankrupt system where our existing patients don't have access. So that's where half the money goes, to Medicaid. The other half of the money goes to federal taxpayer subsidies to individuals who purchase their health insurance in the state health insurance exchange. Now maybe you've heard of the exchange or heard that term. This session down in Olympia, our legislature passed 26 healthcare related bills. The one that was really critical was the one that set up the state health insurance exchange. And Washington is leading the charge in this. There are 25 states who haven't done anything, do not plan to do anything, don't want to set up an exchange. Washington is one of 15 that's already done it. And the way the health insurance exchange will function, it will function like a brokerage or a clearinghouse. where insurance plans will be sold through the exchange. And those plans, the benefits in the plans will be dictated by the government. They'll tell insurance companies what they can put in those plans. And the pricing will be determined by the government. And then individuals and small employers, anyone with less than 100 employees, will be able to access their health care through the insurance exchanges. So where's the money coming? Well, if you're an individual and you make less than 400% of the federal poverty level, you will qualify for a subsidy if you purchase your insurance in the exchange. So start. What's 400% of the federal poverty level? Last year for a family of 4, it was $89,000. And this is tagged to the cost of living and inflation, such that by the year 2016, a family of 4 making $96,000 will qualify for government subsidies in the exchanges. That's where half of the money goes. We're not talking about a safety net. We're not talking about poor people. We're talking about solidly middle class, upper middle class. I mean, $96,000, that's a lot of money. And that is where half of the money goes from the Affordable Care Act. So, okay, so where's money come from? Where are we going to get this $1 trillion? And the money comes from 2 sources, essentially, 2 places. Again, if we take that $1 trillion, about $500 billion, or a little over $500 billion, comes from a cut to Medicare. Now, many of you know what Medicare is, but just to kind of get everybody up to speed. Medicare was passed in 1965. It's health insurance for our seniors. If you're 65 and over, you qualify for Medicare. Medicare has problems. Medicare, like Medicaid, absolutely must be reformed. By 1990, 25 years after the legislation passed, Medicare was 7 times over budget. The unfunded liability in Medicare is at least $40 trillion. It needs to be reformed. But it needs to be reformed in a meaningful way with a scalpel, not with a chainsaw. And what the Affordable Care Act does is it cuts over $500 billion right out of Medicare, mostly on the provider side. So the cuts come in reimbursement for hospitals, dialysis units, ambulances, nursing homes, and doctors. Now the problem with existing Medicare is Medicare pays about 70% to providers what private insurance does. So even with existing reimbursement, docs, family care practice, internal medicine doctors, they have trouble keeping their doors open and paying their overhead with Medicare reimbursements. And what the Affordable Care Act will do is it will lower those reimbursements even further, making access for our Medicare patients that much more difficult. So that's where half the money comes from, cut to Medicare. The other half of the money comes from the largest tax increase in the history of this country outside of war. There are 21 either new taxes or increases in taxes that we already pay. There will be taxes on insurance premiums, health insurance premiums. Health insurance companies will be taxed. Medical device manufacturers will be taxed. Drug companies will be taxed. So you can see, this isn't just the rich. Anyone who uses health care will have these taxes passed on to them and pay more for your insurance premiums, more for your drugs, more for your medical devices. A couple who makes more than $250,000 a year. You will see almost a 1% increase in your payroll Medicare tax, and you will see a new 3.8, almost 4% tax on unearned income. And unearned income is dividends, capital gains, rental property income, in certain cases, sale of your home.
Interest?
Interest, yeah, that's unearned, yeah, you bet, that's unearned. And
Yeah.
here's the critical thing, folks, that $200,000, that's not tagged to inflation or the cost of living. So as the country prospers, people make more money, that is going to function just like the alternative minimum tax, and it's going to capture more and more individuals. And so the rich are probably middle class now from an economic standpoint. So that sort of thumbnail sketch is what the Affordable Care Act is all about. Now you will hear and you will see in the press all of these great things. And the proponents of the Affordable Care Act, they're hammering these things at the American public. One of the things is insurance plans now have to cover kids up to age 26. Well, come on, folks. Those are the young and healthy. They don't use insurance, so that's not a big deal. Small employers can now get tax credits, part of the Affordable Care Act. It's a great thing. Less than 10% of employers who qualify have picked up those credits, simply because the regulatory impact, regulatory burden to do it is so great. They just haven't bothered. And this can go on and on and on. So anytime you see some great, huge headline, the Affordable Care Act is doing this, take it with a grain of salt, because the fundamentals are the fundamentals. So that were the first two things we wanted to cover. The third thing, just real briefly, where do we stand today? We've had almost 2.5 years of the Affordable Care Act. Like Teresa said, I'm a retired surgeon. Surgeons as a group, we essentially wanted to wash our hands of this entire piece of legislation, except for the plastic surgeons. And they wanted to put a new face on it. And except the anesthesiologists, like Jackie's husband, they thought it was a gas. And the dermatologists, they didn't want Congress to do anything rash. And then finally, the obstetricians, the baby doctors, they thought that Congress was simply laboring under a misconception. Pass this thing. So anyway, so where do we stand? Well, let's remember the things that the American public was promised. First of all, it's going to decrease the cost curve. Well, the Congressional Budget Office has had a chance to look at this. The chief actuary for the Center for Medicare and Medicaid Services, an individual named Richard Foster, has had a chance to look at this. Budget committees from both the U.S. Senate and U.S. House have had a chance to look at this. Now, the CBO just came out with numbers yesterday. They said, no, not 940, it's going to be $1.1 trillion. That's net. The gross number that they came out with in March was $1.76 trillion over the first 10 years. New estimates on budgeting are somewhere, it's going to add to our debt and deficit somewhere between $300 to $550 to $600 billion. The CBO yesterday said it's still going to decrease our budget by $100 billion. And what they didn't tell you was that's estimating a cut to Medicare of almost $750 billion instead of the original $500 billion. So they're fudging the numbers here, folks. Foster, the chief actuary, he said with the Affordable Care Act in place, instead of spending 17.5% of our economy on health care, by the year 2020, with the Affordable Care Act in place, we will now spend 21% of our gross domestic product on health care. So in no way will this bend the cost curve down. How about universal coverage? Nope. Out of the 55 million people without health insurance, for one reason or another, but let's take that number, 55. When the debate started, at least 20 million will still not have health insurance for one reason or another. So this will not provide universal coverage. If you like your health insurance, you will be able to keep it. Nope. The tip of the iceberg lowball number is at least 14 million people will lose their current health insurance. And we in the policy world see that, like I say, as the tip of the iceberg. We see that number growing much, much larger as employers do the math and they figure out it's going to be much cheaper to drop employee coverage. Now, Deloitte, which is a large national organization, they polled a series of employers just, well, actually they did their report here within the last week, and they found a number of 10% were considering or planning to dump employee health coverage. Last winter, one of the large polling research organizations in the country called McKinsey, they did a relatively scientific thing. They looked at large employers and small employers. And what they found on the small employer side, they found that the response was 30% of them said we are planning to drop our employee coverage, and 50% said we are considering dropping employee coverage. And the really kind of staggering number here with large employers, 10% said we are definitely dropping coverage, and up to 30% said they were considering. And by large employers, I mean Boeing, Microsoft, Packard, and so forth. So we're looking at something, as I say, that 14 million who are going to have to find their own health insurance in the future. That's the lowball number. And as those people go out, as those individuals go out and they say, where can I find health insurance? They'll look at the individual market. If they make less than 400% of the federal poverty level, they'll look at the state exchange and they'll say, hey, that state exchange looks pretty good. So the estimates on how much money we're going to spend in that state exchange, again, those are probably lowball numbers as more and more people go into the exchange, into what's essentially government-determined, government-priced healthcare. Waste, fraud, and abuse. There's nothing in this legislation that's going to eliminate waste, fraud, and abuse, and it accounts for at least 10%, perhaps as high as 20 to 30% of the cost of Medicare or Medicaid today. And then improving quality, the last thing, in no way. The way we look at this is if our Medicaid and Medicare patients are having a more difficult time accessing health care, in no way will that improve quality. So those are the things we were promised, and that's kind of where we stand today. Now, just real briefly, let me kind of give you an update on the Supreme Court decision, because this was, it was sort of breathtaking in how they ruled. They spent 3 days, 6 hours over 3 days, which for the U.S. Supreme Court was an incredible amount of time and work. So 6 hours of work over 3 days, I want that job. I don't care. Come with me, we want that job. Anyway, so there were 4 things that they heard. On Monday, the first day, they actually heard arguments about whether they could take the case. And the reason for that was there is a provision, it goes back to 19th century law called the Anti-Injunction Act, which, sort of the Cliff's Notes version here, it says the Supreme Court really can't rule or hear arguments on any piece of legislation dealing with taxation until the taxes kick in. Well, the taxes don't kick in until 2014. So the Supreme said, well, okay, it's not a tax. Let's hear the case. And even one of the more, arguably, one of the more liberal justices, Ginsburg, said, this is not a revenue creating piece of legislation, so in no way is this a tax. I mean, those were kind of her words during the argument. So the case then went to Tuesday, and Tuesday was the meat of it. That's when they heard the individual mandate. And the proponents said, okay, first of all, Congress has the right to pass this legislation that falls under the Commerce Clause. Healthcare is an interstate activity, and healthcare is an interstate activity, so it falls under the Commerce Clause. So if you don't like that, Supreme Court, then it falls under the Necessary and Proper Clause in the Constitution. Congress can do anything they want with this Necessary and Proper Clause. And then the third thing, way down the list, was it's a tax. That penalty, if you don't have health insurance, is a tax. And the opponents argued, well, wait a minute. The Commerce Clause does not apply to inactivity. And not purchasing something is inactivity. So you can't legislate that. The Necessary and Proper Clause, they argued, if Congress can tell us to do this, purchase health insurance, they can tell us to do anything under the Necessary and Proper Clause. So that got thrown out. And then they said, in no way, then the third argument was, of course, this is not a tax. It's a penalty, it's a fine, but it's not a tax, right? And so then the third day, they heard arguments based on severability. In other words, if the individual mandate was found to be unconstitutional, would the rest of the law stand? And then the fourth thing they heard, and the second thing on that last day, Wednesday, was, what about the Medicaid expansion? Is that a states' rights issue, or can Congress actually force states to increase their Medicaid rules? So, just real briefly, they heard arguments at the end of March, and they came out a couple of weeks ago with their decision. And like I say, it was breathtaking. Justice Roberts voted with the 4 liberal justices and said this is constitutional based on Congress's ability to tax. Why the Anti-Injunction Clause doesn't hold there, I don't know. But they call it a tax, and very clearly Congress does have the ability to tax the citizens of this country. So that's the way that ruling came down. And then the other interesting thing was, which was a surprise to most of us, the Supreme Court did say that this expansion of Medicaid was a states' rights issue, and that the law would not necessarily stand, that provision of the law, the expansion of Medicaid, and it would be a state-by-state opt-in or opt-out of the Medicaid expansion. And I heard 3 hours of testimony yesterday down in Olympia, and they're charging full ahead to expand the Medicaid program in this state. So that's neither here nor there. But anyway, just real briefly, you know, in 30 minutes or less, that's the Affordable Care Act and where we stand in the Supreme Court decision. So do we have time for a few questions, I suppose?
Yeah, we do.
Yeah.
When you're talking about companies that are going to keep the insurance or not, just to simplify it, you're talking about private companies. What about public employees? Because that's taxpayer. Are they going to, you're talking about the percentage that are going to keep it or drop it.
Yeah. No, those were all public companies that were
Okay, but if you're a public employee.
Yeah.
Government employee.
If you're a government employee, yeah, the government's not going to drop their health care benefits.
Okay, so it's 100% then on that?
On that side?
Yeah.
Oh, for sure, yeah. Yes.
How come when this all came about, that AARP was supposed to represent a lot of the elderly people, how come they were so much in favor of it?
Well,
Because they got money out of the deal.
yeah, well, there are two reasons. One, the administration of the AARP is extremely liberal. And if you talk to them, what they want is a Medicare for everybody. I mean, that's their end game. And then, like you say, they get a certain amount of money selling co-insurance. And that's a huge profitable line item for them. And they had a very prominent seat at the debate table and so forth. Yes, sir.
When we're successful in replacing Obama and having a Republican Senate as well as a House and repeal this nonsense,
Yeah.
what is your vision of what healthcare reform should look like?
Well, that's a great question. We could spend another evening talking about that, but just basics. Okay, there are really two choices as far as healthcare is concerned. Let's start though with the problem of healthcare. And the problem with healthcare is the cost. And it doesn't matter whether you're a liberal, a conservative, libertarian. Everyone can agree the problem with healthcare is cost. There are two ways to bring the cost down. One is to allow the government to do it through a rationing mechanism. And the other way is to allow patients, as consumers of healthcare, to make their own healthcare decisions and spend their own healthcare dollars. So anything, and obviously we believe in the latter. We believe that the patient is the most important person in this entire equation. And it was sort of the patient that got forgotten in this entire debate. So our whole philosophy is to give the patient more power. And you do that by giving them more choice. Let's open up the insurance business. Let's be able to purchase insurance across state lines, things like that. Let's take these 58 mandates that Olympia puts on insurance policies sold in the state. They're for good things, but let's not put that kind of a burden on every policy sold in this state. Let's change the tax code so that individuals can deduct the cost of their health insurance just like employers do. Let's promote insurance as high deductible, catastrophic sorts of things to take care of major medical problems, health savings accounts to take care of day-to-day kinds of things. Meaningful reform to Medicare and Medicaid. Again, by putting patients in charge. Let's give Medicare patients, instead of just an open-ended kind of thing where prices are regulated by the government and access is driven down, let's give patients premium support or vouchers or whatever you want to call it, so that they can come into the entire private market and find their own health care, their own health insurance. Same thing on the Medicaid side, and then we need meaningful tort reform. So, shameless plug here, if you really want to hone in on that, buy the book.
The book.
And it's a real simple book to read. It's not a policy book. It's 100 pages. Read it in a couple nights. Yes, ma'am.
It sounds to me like those of us who want to keep health care, our premiums are going to go through the sky. Because you're going to have all the people who are willing to pay the penalties, even if I heard you right, 2.5% of gross income. You've got to have a reasonable gross income to care about that. And so they're going to pop in when they break a leg or they get pregnant or whatever the heck.
Yeah.
And the rest of us are going to keep paying and paying and paying. Or we're going to start looking at paying our 2.5%. And the whole system's going to just explode.
Yep. That's exactly right. We have an annual healthcare conference. We held ours 2 weeks ago. Over 500 people attend between Spokane and Seattle. And one of our panelists was a gentleman named Jeff Rowe, who is Senior Vice President at Primera and the CEO of LifeWise Health Plan, which is kind of their high deductible plan. And it was staggering. He outlined where premiums are going to go over the next few years for Premera and Premera customers. And it's, 15% here. I mean, he had this line itemed out, 15%, 10%. Bottom line, over the next few years, premiums will go up 50 to 70%. And it's for the exact reasons you're talking about. They don't know how to mitigate risk. So you say, well, what's going to happen? People aren't going to pay that. Well, they may not. And so what long-term or intermediate term will happen is our health insurance companies will essentially close their doors to private products. They will become public utilities. They will become pass-throughs from government funds going out to providers. And again, that's what we see.
All these people that have been asking the administration for exemptions, what are they going to do?
Well, that's a good point. There have been something like 1,800 waivers that have been granted to date. And, so there are certain companies with, for example, low-wage employees. McDonald's, for example, has gotten waivers. A number of labor unions have gotten waivers. So they're out of the system. The point, though, is what will they find in the individual market?
If everything else is tanking, where do they go?
Yeah, exactly. We're all in this together. We're going to all tank together, I'm afraid.
And another part of my question was that it was explained to me that the cross-state competition won't work because the insurance companies depend on working in a geographical area and negotiating rates with particular hospitals, and if you just opened up the whole market to use that bargaining power, and that system's going to work.
Well, you raise a good point. If you look at the existing program we have now, somebody asked about what I see as reform. The other thing that needs to happen is on the provider side, we need a paradigm shift there, and what that means is hospitals, doctors, they've got to start showing their rates. They've got to compete on price as well as quality. As soon as they start doing that, exactly. As soon as patients become consumers, there's going to be a huge movement in this country, and we're seeing more of it. Here's the tragedy, folks. We're seeing more of this. High deductible plans are taken off. They're like IRAs when they first came out. Health savings accounts, they're like IRAs when they first came out. More and more individuals, more and more employers are using them. And it just gives patients more consumer power to get their own health care. And the Affordable Care Act is going to almost virtually eliminate that. Yeah.
What about education, more doctors?
Well, yeah, that's a really good point, sure. We're going to provide health care for 32 million more individuals and not create any more physicians.
I guess I mean more than that. I'm just thinking, of family members or friends where their kids try 2 and 3 years to get into med school.
Yeah.
They do finally make it eventually and become fine doctors.
Yeah.
And I'm saying to myself, why do people have to try 2 or 3 years to get into a med school if we need doctors in this country, good doctors in this country? Instead, I'm looking around and saying, well, I guess we don't produce good doctors in this country anymore because they're from China and from India and all over. Not that there's anything wrong with it, but I'm having a hard time figuring out why good people can't get into med school for 3 or 4 years and we're importing medical doctors.
You raise a great point, and again, we could spend a whole evening on this. We did a paper last year on the doctor shortage that exists now and the looming terrific, terrible doctor shortage that's coming. What you need to understand, bottom line here, folks, is the government has controlled the number of medical schools, the number of spots in those medical schools, the number of interns and residents that train. So again, as it's top-down central planning, right? They think they can figure out how many doctors and what kind of doctors we need. That's crazy.
But how did they do it? How do they control the schools?
By the dollars.
I'm asking, how do they control the schools? How does the federal government control the schools?
Why is it limited?
Why is it limited?
No, I think
well, they control it by funneling grants and money and things like that. You want more doctors, you put more money into the program, and you build more schools. But you want fewer doctors, you cut off some of the funding. And so universities can't train as many physicians, they can't train as many residents and so forth.
Okay, so what you're saying,
follow the money.
Okay, so what you're saying is the federal government is not supporting them with grants.
Mhm.
like they do other schools, like they do art schools or
No.
football teams or whatever they're doing to schools?
No, that's only part of it. They still support medical schools. But again, they control the number of medical schools and the number of spots that are open in medical schools. Why?
But that's what we're trying to
They
figure
do
out
have
how
a lot
and why,
of
by just not
Well,
giving.
they do it by money. And the why is because,
They think they
you
know.
know, they think they know how many doctors we need.
Is it gonna be like double dipping? So if you have an employer who says, I'm gonna pay the penalty, I've got all these employees, I'm not giving them medical insurance because the penalty is worthwhile. Do the employees have, do they have grace, or do they now get penalized if they also don't go out and buy medical insurance? Or is that too detailed?
No, there's no grace. No, they have to have health insurance.
Okay.
You've got to show
So the
it.
government could collect from the employer, and then
Yes.
the employee who says,
Yeah.
I'd rather pay the
Choose not
penalty.
to, right.
Sure,
And nobody's got insurance, but we're all paying penalties.
Sure.
Okay.
yeah, exactly.
You
Yes,
got it.
Yeah.
We're talking about two things,
Okay.
insurance, the cost of insurance and the cost of healthcare. On the healthcare side, is tort reform ever entered into a way to
No.
reduce the price? Because this
Well-
it's not covered in the bill, is it?
No, well, there are pilot programs. Who knows what a pilot program is? And there are a few dollars that they threw at that so that they could, you know, go out and say, yeah, we have tort reform. Tort reform, the legal system costs, in general, the overall healthcare delivery system, somewhere probably in the neighborhood of at least 10%. There are numbers that are as high as 20% of our costs are because of the legal system. And that's attorney's fees, court costs, but it's also defensive medicine that's practiced. And there's nothing in the Affordable Care Act that addresses that meaningfully.
I hear a lot of people seem to think that the answer is more of these grants. The thing is as you throw more money into grants, the colleges seem to eat all that up and just raise their rates that much more to take it all in, and they get it, and the problem still is going to exist.
Yeah, yeah. Yeah, that's a good point. And then grants, you also trip something in my mind. What the federal government is doing now is giving grants to states to help them consider expanding Medicaid and to set up their insurance exchanges. And that's like giving a little bit of heroin to an addict, right? Okay, so, I mean, our state legislatures down there in Olympia, they look at this and they say, geez, we've got $128 million from the feds. Let's set this exchange up. Not realizing that a couple years from now, when those grants dry up, Washington state taxpayers will be on the hook for the administrative cost of that exchange.
But hopefully they'll be out of office.
Yes, ma'am.
Okay, I had heard this before, and I just read it in your book, that eventually the Medicare Advantage plan is going away.
Yeah, I didn't cover that, but
Okay, well, I have Medicare Advantage.
yeah.
So people like me, where do we have to go into the state exchange to
No.
get health
No.
care, or?
No, let me just so everybody's on the same page here. There are 4 parts to Medicare, and Medicare A, which is hospital, Medicare B, which is pays providers, Medicare C, which is Medicare Advantage, which covers sort of everything, and then there's Medicare D, which is the prescription drug benefits. What will happen, that over $500 billion cut to Medicare, a lot of that will be in Medicare Advantage, and there are about 7.5 million seniors in Medicare Advantage. It's one of the most popular parts of Medicare, one of the fastest growing parts of Medicare. What will happen if that goes away, you'll go back into A, B, and then have the option to sign up for D, for the prescription drugs. But you'll go into traditional Medicare, Medicare A, Medicare B.
Okay.
Yeah, maybe one more question,
Okay.
but I'll let you guys go.
I know people talk about that health, or what is it, death panel or whatever.
Yeah.
But I mean, isn't there a reality? Part of the reason why our medical expenses are going up is because there's so many more procedures today than there was 20 years ago. I'm 67 years old, 69 years old. I mean, now we got hips, we got fingers, we got toes, we got
Right.
everything we replant. And just aside from that, my mother was 95 years old when she passed away. She was being taken care of hospice in a care center, which we paid for privately. And she managed to get up and fall and broke her hip. And they said, would you like to take her to the hospital to have an exam, or we can do it here? We said, fine, let's do it here. And then they said, she did break her hip. Would you like to take her to the hospital for a hip replacement? I said, are you kidding me? She's 95 years old. She's near the end of her life. A hip replacement? Under hospice? And they said, well, because it's not life-saving, but she's entitled to it with Medicare. I was blown away
Yeah.
because it made no sense to even offer it.
Right, and you touch on some issues there, and again, we could spend a whole evening discussing them. But think of it this way, folks, you're absolutely right, that our medical devices, our drugs are much infinitely better than they were 50 years ago. But I had one of the first cell phones, came out in the early 80s, right? It was like this big, so it had a handle on it, right? So it was portable. Okay, my cell phone now is like this big, and I can talk to people, and I can get my email and everything else. I paid, I can't remember, it was either $300 or $400 for that cell phone back in 1982, 83. I paid $49.95 for my cell phone now. So what's the difference there? Well, cell phone business wasn't centrally planned, top-down, government-run, right? But look at healthcare. I mean, the reimbursements come from government, from employers, have no idea what a heart valve costs, or a stent, or a hip replacement. And that's, again, what we need is more consumerism in healthcare, so we get more transparency, and we know what the actual costs are, and we can drive these costs down.
Can we drive that hip replacement down to $50?
Might be able to. I don't know.
Talk to the defense
Thanks very
contractor.
much, folks. I'll be happy to stay afterwards if you have